All right, we're live.
Okay, thank you. Welcome back to the Senate Committee on Health and Welfare. We are shifting to a conversation about the audio-only provisions in our flexibility bill regarding flexibility provided to healthcare providers during the pandemic. And we have with us Representative Lori Houghton from the Health Committee in the House, and she's going to just give us an overview of what her committee worked on and is recommending to us. So welcome, Representative Houghton. Take it away.
Thank you. For the record, Lori Houghton from the House Healthcare Committee, and I appreciate the opportunity to kick us off on this, what we feel is really important legislation moving forward. So as everyone may remember from the emergency legislation last year, we put in place a working group to study audio only. And that working group came back with a very comprehensive and detailed report. It's one of the best ones I've seen, focused on audio only. And from there, our group took a lot of testimony over the last couple of weeks from providers and payers and insurers on extending audio only as a means of access for medical care. And so there were basically two decision points. One was, do we allow for audio only? And then the second decision point was, at what payment reimbursement? Do we dictate a payment reimbursement, or how do we move forward with that? And I will just say up front, there is resistance from the payers in our language that we've put forward, but we heard a lot from providers and patients that for some, audio only is really the only way they may have access to medical care, whether it be for transportation, disabilities, childcare issues, work obligations, or in some for just the anxiety of being in a doctor's office, that having the option to use audio only opened up medical care. With that determination, we felt it was important to allow this access to continue. And we also felt it was important that until we had the data to fully understand the utilization and the quality of audio only, we should consider it at pay parity to what would be an in-person visit, which is what is happening during the emergency. We took into account some of our key tenets were that it's clinically appropriate and medically necessary, obviously, that the patient has a choice, and that, you know, if they want an in-person visit, they have that capability to have that in-person visit. And that informed consent is important and includes both the options available in person, audiovisual or audio, but also that there may be costs associated with an audio only medical appointment. So with that, we came up with this language that we are putting forward to the Senate. Our committee did not obviously take an official vote since it's not a bill coming from our committee, but we did vote 11-0 on this language. I will add, there's a caveat. There's a couple things that came up after our committee voted, and we've worked with Jen this morning, Legislative Council, and both our chair and vice chair in our committee, and we're comfortable presenting that to you as well. That's it.
Great. Thank you, Representative Houghton. Does anybody have questions at this point, or are we ready to take a look at the language itself? Okay, great. If you're able to stay with us, that would be fantastic. And Jen, if you want to take it away, I don't see it on the website yet. I don't believe it's there, but if you can share your screen, then that would be helpful.
Yes, let me look. I know Nellie did think she was able to post it, so it may be a matter of refreshing. I will take a look. Do see it on the website, so you should be, but there's actually two documents, so which is, I had sent her two, so it's a little confusing. You'll want the one that's DR 21-0873 draft 3.3.
Great, I see it now. Does everyone else see it? If they want to look at it on their own screen. But Jen, maybe it would be helpful for you to share as well.
Sure, absolutely. All right, so you should be able to see the language. And so I had formatted this just for, so you understand, as a committee bill, it was not clear what form it was going to take. And so it seemed simplest to look at it as a committee bill. It sounds like at this point it may get dropped into what you are working on, which is also very easy for me to do.
Hey, Jen, excuse me, is there a way for you to make it a little bigger?
Sure. Zoom in a bit. Is that better? You want bigger?
Yeah, that's a little better. Thank you, Jen.
Okay, we can keep going. All right. So the first thing that this does is in the health insurance statute. So in Title 8, Chapter 107, there's an existing section and subchapter on telemedicine, which I broadened to call telehealth to include this audio only aspect. And so we have some definitions. So it's a new section, coverage of healthcare services delivered by audio only telephone. We have some definitions. First is of a healthcare provider, which is a pretty standard definition that we use: a person, partnership, or corporation other than a facility or institution that is licensed, certified, or otherwise authorized by law to provide professional healthcare services in this state to an individual during that individual's medical care, treatment, or confinement. And then we have health insurance plan. And so this is where you'll see the first of these bits of new language. So I tried to indicate for people who had been following along with what House Healthcare was doing, what had changed since the version that was looked at late yesterday afternoon. So in the definition of health insurance plan, we have our sort of general definition that references a plan, policy or plan offered by a health insurer. It does include Medicaid, but we have this caveat here that it's to the extent permitted by the Centers for Medicare and Medicaid Services. There is still a fair amount of uncertainty about what they will allow coverage for after the pandemic, after the public health emergency ends. So this limits Medicaid's exposure to what is permitted under federal law, which is what's required by for our federal match. And then any other public health care assistance program offered or administered by the state or any subdivision or instrumentality of the state. But we're not talking about policies or plans that provide coverage for a specified disease or other limited benefit coverage. So what this long definition basically says is major medical health insurance and Medicaid to the extent the federal government allows Medicaid to participate. Then it requires a health insurance plan to provide coverage for all medically necessary, clinically appropriate healthcare services delivered remotely by audio only telephone to the same extent that the plan would cover the services if they were provided through in-person consultation. And it would include services that are covered when provided in the home by home health agencies. So some of this language is taken, some of it is based on what is in the telemedicine insurance coverage piece, and some of this is based on what DFR's current emergency rule requires. This next piece is the reimbursement parity. It requires the plan to provide the same reimbursement rate for services billed using equivalent procedure codes and modifiers, subject to the terms of the insurance plan and provider contract, regardless of whether the service was provided through in-person consultation with a healthcare provider or by audio-only telephone. So that's the reimbursement parity. Plans have to pay the same amount to the provider if they're billing using equivalent procedure codes and modifiers, regardless of whether it was in person or by audio only. And then some new language in here saying, but that reimbursement parity piece doesn't apply in the event that a health insurer and healthcare provider enter into a value-based contract for healthcare services that include audio only telephone services. And this was based on a request from the insurers that if they're moving toward some of this value-based payments, that they not be tied to that fee-for-service reimbursement scheme. It allows a health insurance plan to charge an otherwise permissible deductible copayment or coinsurance for a healthcare service delivered by audio-only telephone, as long as it's not more than what would be applicable for an in-person consultation. And then it says a plan cannot require a provider to have an existing relationship with a patient in order to be reimbursed for healthcare services delivered by audio-only telephone. So it doesn't have to be only with established patients. It could be with a new patient if that was clinically appropriate, medically necessary, and clinically appropriate. So that's the first section, which is really focused on the coverage for audio-only telephone services. And then we get to section 2, which is in Title 18, again, in a section relating to, or subchapter relating to what was telemedicine, and now we're expanding that to call it telehealth. And so this is looking at the provider side of things and what providers have to do when delivering healthcare services by audio-only telephone. And so a lot of these provisions are similar to things in the telemedicine and store and forward section, but there were enough differences that for both of these, it really made sense to treat them separately in order to not have a lot of exceptions that were hard to follow. So we're piggybacking on the same definitions of health insurance plan and healthcare provider, and also the existing telemedicine definition from the insurance statutes. And then it says, subject to the limitations of the person's license, and for Medicaid patients to the extent permitted by CMS, a healthcare provider may deliver healthcare services to a patient using audio-only telephone if the patient elects to receive the services in this manner and it is clinically appropriate to do so. There's a lot of focus here on what is clinically appropriate. Healthcare provider must comply with any training requirements imposed by their licensing board on the appropriate use of audio-only telephone in healthcare delivery. It requires a healthcare provider delivering healthcare services using audio-only telephone to include or document in the patient's medical record the patient's informed consent for receiving services this way, and that's spelled out a little bit more in subsection C, and the reason or reasons that the provider determined that it was clinically appropriate to deliver healthcare services to the patient by audio-only telephone. Specifies that a healthcare provider cannot require a patient to receive healthcare services by audio-only telephone if the patient doesn't want to receive the services that way. It also requires a healthcare provider to deliver care that is timely and complies with contractual requirements and cannot delay care unnecessarily if the patient elects to receive services through an in-person visit or telemedicine instead of by audio-only telephone. So this was to address potential concerns that providers might try to influence patients' choices by offering them a much quicker telephone visit even though the person really wanted to receive an in-person or telemedicine visit. Then we get to the informed consent parts. So a healthcare provider delivering services by audio-only telephone must obtain and document the patient's oral or written informed consent for the use of audio-only telephone prior to the appointment or at the start of the appointment, but prior to delivering any billable service. The informed consent must be provided in accordance with Vermont and national policies and guidelines on the appropriate use of telephone services in the provider's profession, and must include in language that patients can easily understand that the patient is entitled to choose to receive services by audio-only telephone, in person, or through telemedicine to the extent clinically appropriate. That receiving services by audio-only telephone does not preclude the patient from receiving services in person or through telemedicine at a later date, so it doesn't lock them in to just audio-only. An explanation of the opportunities and limitations of delivering and receiving healthcare services using audio-only telephone. Informing the patient of the presence of any other individual who will be participating in or listening to the patient's consultation with the provider, and obtaining the patient's permission for the participation or observation. And finally, whether the services will be billed to the patient's health insurance plan if delivered by audio-only telephone, and what this may mean for the patient's financial responsibility for co-payments, co-insurance, and deductibles. So for example, letting the patient know that this visit will be billed like an in-person visit, which would likely mean that their regular cost sharing for an in-person visit would apply versus something that might be billed differently and could contain a lesser or no cost sharing. For services delivered by audio-only telephone on an ongoing basis, so something like meeting with a mental health counselor on a weekly or other ongoing basis, the healthcare provider only has to get the consent at the first episode of care. They don't have to go through this same informed consent process weekly if these are services on an ongoing basis by audio-only telephone. If the patient provides oral informed consent, the provider must offer to provide the patient with a written copy of the informed consent. If the patient wants to see what they had agreed to, they can ask to be provided with a written copy, or they should be offered the opportunity to receive a written copy. Notwithstanding any provision of this subsection to the contrary, a healthcare provider shall not be required to obtain a patient's informed consent for the use of audio-only telephone services if it's a medical emergency. And a healthcare provider may use a single informed consent form to address all telehealth modalities, including telemedicine, store and forward, and audio-only telephone, as long as the form complies with the provisions of that telemedicine and store and forward section, that's 9361, and of this section. Neither a healthcare provider nor a patient shall create or cause to be created a recording of a provider's telephone consultation with a patient. And then it prohibits the use. Audio-only telephone services shall not be used in the following circumstances. And these are both in the mental health context for the second certification of an emergency examination, determining whether someone is an individual, whether they're a person in need of treatment, or for a psychiatrist's examination to determine whether someone is in need of inpatient hospitalization. So both of these require at least audio, video, telemedicine, if not in person. Then we get into some session law provisions about to enable some consistency in billing and allow for data collection. So on or before July 1st of this year, the Department of Financial Regulation, in consultation with DEVA, the Green Mountain Care Board, representatives of healthcare providers, health insurers, and other interested stakeholders must determine the appropriate codes or modifiers, or both, to be used by providers and insurers, including Vermont Medicaid to the extent permitted by CMS, in the billing of and payment for healthcare services delivered using audio-only telephone, in order to allow for consistent data collection by insurers, maintain reimbursement rates equal to those for in-person services, identify appropriate codes for services that do not have in-person equivalents, and minimize the administrative burden on providers. So this is directing them to come up with this kind of a common set of coding for billing and payment that allows for data collection, the reimbursement parity, identifying codes to be used where there isn't an obvious in-person equivalent, and also trying to do this in a consistent way so that there isn't a whole separate set for providers to deal with for each payer. To the extent possible, the use of codes or modifiers or both would be done in a way that allows data on the use of audio-only telephone services to be identified using VCures. Not later than January 1st of 2022, all Vermont licensed healthcare providers and health insurers offering plans in Vermont must use the codes and modifiers determined by DFR under that first subdivision when delivering services by audio-only telephone. So there's a period of time between when they're identified, which is by July 1st, and January 1st for everyone to kind of get their billing systems into alignment in order to make sure that this is happening so that the data can be collected for plan year 2022. And this new language would say that Vermont Medicaid would participate to the extent permitted by the Centers for Medicare and Medicaid Services. As I said, things are kind of in flux there, so trying to give appropriate latitude to or flexibility to Medicaid while also including them to the extent possible. On or before December 1st, 2023, DFR, VPQHC, and to the extent VCures data are available, the Green Mountain Care Board would present information to your two committees regarding the use of audio-only telephone services in Vermont during calendar year 2022. So this is allowing for some time after calendar year 2022 ends to finish the claims trail and figure out what all the services were that were delivered using audio-only telephone. And then you'll see there's some other requirements for the presentation that they'll need that time to put together as well. So the department must consult with interested stakeholders in order to include in its presentation information on utilization of audio-only telephone services, quality of care, patient satisfaction with receiving healthcare services by audio-only telephone, and the advantages and disadvantages of reimbursement parity, of reimbursing providers the same amounts for in-person and audio only. Section 4 is a piece that fits directly with what we've been working on in your bill. this would continue to allow DFR, oops, it should be capitalized there, to consider adopting and have the authority to adopt emergency rules to address the narrower piece, health insurance coverage of and reimbursement for telephone triage services. These telephone calls used to determine whether someone needs an office visit or other service. So that's not really in the scope of what we were doing in the audio-only telephone services. Generally, this would allow DFR, consistent with the timing and the rest of your bill, to adopt emergency rules that would remain in effect until not later than April 1st of 2022. So through March 31st, 2022, to allow telephone triage services to be covered and reimbursed during this time of the pandemic. Section 5 is kind of a conforming change in the existing statute on telemedicine and reimbursement parity in telemedicine. This is similar to the language that was, or identical really to the language that was put in for the audio-only telephone, saying there's an exception for reimbursement parity in the event that a health insurer and healthcare provider enter into a value-based contract for healthcare services that includes telemedicine or store and forward means. And then we have a prospective repeal. It sunsets that reimbursement parity piece on January 1st, 2025. So the audio-only telephone reimbursement parity would run through 2024. So just to spell out the timing on this a little bit, you're collecting data through plan year and calendar year 2022. You're getting a report that comes in at just before the 2024 legislative session starts. This parity, reimbursement parity ends on January 1st, 2025. So potentially or presumably the 2024 General Assembly would be considering whether to extend or do something else with the reimbursement amounts for audio-only telephone during that 2024 legislative session. So I just wanted to kind of put those pieces together for you, especially because some of them are a little hard to follow in the abstract. And then the act would take effect on passage.
Okay, thank you, Jen. Senator Lyons asked me to just continue, and we're going to go for another 6 or 7 minutes. Question, Senator Cummings.
Yeah, Jen, this would apply. This would not apply to ERISA. So all the private self-insured plans. Does Medicare cover telephone only?
So that's a great question. That's part of what's in flux with CMS. The indications have been that after the pandemic, they will be shutting off most of the telephone codes that they have been allowing, but there's also some federal legislation that was being proposed that would continue that or expand that in certain circumstances. So unclear yet. What will happen on the Medicare side. And you're right that the self-funded plans are not required to comply with this coverage requirement.
Okay, what about Medicaid?
Medicaid is in here to the extent they're allowed under federal law. So they have been covering this. It is my understanding that they would comply with this requirement unless there was not federal financial participation available as a result.
Okay, so they're iffy. So the only ones we know are going to be impacted are the exchange plans in the state, the private
the exchange
insurance
plans and the large group commercially insured market.
Right, okay, yeah.
Which is not a large market.
The groups. I'm concerned because nowhere in here, and I got my nasty Aunt at the Picnic finance hat on, this is an added service being required of health insurers, and nowhere in here is there any looking at the impact on the cost, especially those exchange plans where we know we have to have actuarial balance. And so if we change one thing, something else has to shift. And that concerns me. If this, I'm going to ask to have it go to finance because it is on on insurance regulation. But it may go attached to this entire flexibility bill, which I don't know that you want to have go there. But I think the impact on the cost of insurance, and it'll be the cost on everybody, needs to be investigated.
Right. So that is the piece around the report that comes back in December 2023, looking at utilization and the advantages and disadvantages of reimbursement parity. I mean, it's not a new covered service. It's a modality coverage requirement, a way of delivering services. So it's not a new type of benefit. It is a requirement to cover it when it same benefits when delivered in another manner. And one of the things that House Healthcare talked a lot about was really wanting to understand whether this was going to whether people were going to be receiving the same services, same amount of services, but just in somewhat varied ways, whether it would increase utilization and whether that was an increase in access that people didn't have access to before. And as a result, maybe if some of that was to catch things more quickly, would there be some downward pressure as well on more expensive conditions that went longer? So I think that's what they're looking to get at from the report back, is very much what the impact is on the costs. And that was an issue also that the insurers brought up a lot, was concern about what this.
We have been asking insurers to cover a lot of things during this pandemic. But the doctors and the provider, they've been being paid. Eventually, those costs are going to come home to roost. And I'm wondering, how do you collect copays over the phone? I mean, right now, if I want to go into the doctor's office or the specialist office, I got to chalk up 25, 50, sometimes it's $90, depending on your plan. So I call up that person. How are we going to collect the copay? You going to trust me to put it in the mail?
Right. Well, and I think they've been dealing with that with telemedicine as well. So I would expect there's some experience there with collecting copays when the patient is not physically present in the office.
Well, at least I'm looking you in the eye. I don't know how the doctor even knows it's me on the other end of the phone.
I see Senator Lyons. I'm not sure if Jen has an answer to that question. So I'm going to
I think those are good questions, I think. But these things are happening now. I've had a couple of telephone appointments in this process before Zoom went into effect, and my physician recognized my voice, and I've also paid by check for appointments that required that. So, I think there are a lot of issues. There are a lot of issues that need reconciling, and so we'll go through the language again just to see if everything is covered. But
are we going to hear from the insurance companies?
Senator Hardy, I see. Houghton might say something.
Exactly. So, thank you, Senator Lyons. I wanted to give Representative Houghton a chance to weigh in since she's here with us today, and then we're going to wrap up. And I think Senator Cummings, that Senator Lyons can answer your question about who we might hear from. But first, let's go to Representative Houghton.
Thank you. And I'll just take a moment, just a couple of comments on the questions that have been asked so far. We discussed this a lot and weighed the pros and cons to the potential cost, And what we heard from many of the providers and patients is that this isn't an additional cost. It is just another way of having access to medical care that works for the patient and is still clinically appropriate. And we did hear from some patients who said, I do not want to have to pay a copay if I'm an audio only visit. And so that is the informed consent piece and the options to allow the patient to choose which type of care, or I guess the modality of the care that they're receiving. But I do want to be clear that the insurance, the companies, the payers had a lot of concerns with the reimbursement at pay parity. But the testimony we heard led us to believe that the access right now is most important, and to be able to get to the answers that the payers were asking us, we needed to collect the data. Thank you.
Thank you, Lori. Representative Houghton. I think we're at the time that we targeted to finish up so that we can take a little break before the floor, unless there are any super quick questions before we wrap up. And this is on the agenda, I believe, for Tuesday, is it, Senator Lyons, or Wednesday of next week?
It will be on for Tuesday.
For Tuesday, that's what
Yeah.
I thought. So we'll get
Not
back.
there yet, but it'll be there.
Okay, write down your questions so we make sure we can get back to this. And thank you, Jen, for your overview, and Representative Houghton for being with us today. And I'll see you, the rest of you, on the floor soon. Thank you. And you can turn off live stream now.